Hi there, my name is Mike Pishfine. I'm an associate professor of GI medical oncology at Johns Hopkins University. Welcome to our case presentations. We have a wonderful panel here with us today, and we're going to go around and meet an individual member first and then discuss some cases. I'll go next to Dr. Fromm.
Yeah, hi, I'm Tyler Fromm. I'm an assistant professor of radiology at the Washington University School of Medicine in St. Louis. I have appointments in abdominal imaging and nuclear medicine, and I'm happy to be here today to go through these cases.
Hello, I'm Pritesh Patel, associate professor of radiation oncology at Emory University, focusing on GI malignancies.
Hi, I'm Dan Catenacci. I'm a GI medical oncologist at the University of Chicago and an associate professor there.
Hi, I'm Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
So this is a 73-year-old female with newly diagnosed stage IIIB T3N2M0 squamous cell carcinoma of the mid-esophagus. And the intended plan was to have concurrent neoadjuvant chemotherapy and radiation therapy. So starting the question to be thinking about as we go through the case is whether adjuvant nivolumab would be offered if there is residual cancer after surgery. So the patient presented, as many of these patients classically do, with heartburn, dysphagia, rib pain, and weight loss of 27 pounds. The patient had a decent performance status of 1. They have a history of fibromyalgia, oral lichen planus, hypertension. There was no history of tobacco, alcohol, or drug use, and a family history of breast cancer in the mother and lung cancer in the father. For the oncologic history, the patient had an endoscopy that revealed a 3-centimeter mass in the mid-esophagus between 27 and 33 centimeters from the incisors, and the biopsy did reveal a squamous cell carcinoma. A CT scan of the abdomen and pelvis revealed the esophageal mass, but no distant metastases, and a PET scan revealed an avid distal esophageal mass with left para-aortic and upper mediastinal lymph nodes. So Dr. Fromm, do you want to walk us through those imaging results?
Sure, gladly. So here we have transaxial, sagittal, and coronal fused PET-CT images from an FDG PET-CT done at the time of initial staging. And we see a hypermetabolic circumferential mass in the esophagus involving kind of the mid and maybe extending into the distal aspects of the thoracic esophagus. We are told, not shown in these images, that the patient had some hypermetabolic lymph nodes as well in the gastrohepatic ligament as well as in the mediastinum. Those were not described in the CT scan, so presumably were relatively normal in size, which I think speaks to the value of PET-CT in these patients for demonstrating local regional spread of malignancy. But there was no evidence of distant metastatic disease on either the CT scan or the PET-CT.
And to that end, to the panel, Dr. Weiser in particular, what would make, which lymph node stations would really make this a potentially unresectable or essentially metastatic squamous cell cancer?
Well, the periaortics are somewhat concerning, although identifying and being sure that they're periaortic versus celiac can be a challenge. And celiac lymph nodes really do not deter us, and of course, either do upper mediastinal nodes.
And would you agree that we tend to give these patients the benefit of the doubt, meaning that if they can get preoperative therapy and the field is still within reason, that we would not spare them esophagectomy, or would you tend to spare them? Would you lean more towards sparing them the esophagectomy because of the risk of recurrence?
No, I agree. I think in in a good surgical candidate, we would give them the benefit of the doubt. We've moved away from looking at lymph node stages and do look at total lymph nodes as prognosis. So if it is resectable, we would move ahead in a good candidate.
Okay. All right, so the patient's treatment plan was to start with neoadjuvant carboplatin and radiation therapy. Dr. Catenacci, what do you feel about the the chemotherapy choice?
I think it's a very reasonable choice. Carboplatin is the backbone of the cross regimen, of which squamous cell tumors were included. And so I favor that along with the radiation. It's a well-tolerated regimen weekly. And I think that's appropriate here.
And given that it's a squamous cell cancer, we know that any thoughts on cis-5FU versus carboplatin?
Yeah, I mean, platinum 5FU, cisplatin 5FU is not my preferred regimen. Cisplatin is a little bit more difficult to tolerate. emerging regimen like Folfox has been considered, particularly for the adenocarcinomas. But for the squamous cell, like I said, I think carboplatin and paclitaxel is my preferred regimen there.
Okay. And Dr. Patel, comments about the radiation therapy, in particular, sort of the radiation field?
Yeah, I think echoing what Dr. Weiser mentioned, just to make sure that the periaortic lymph nodes are something that we can include in a reasonable radiation field. We're now, it sounds like we're extending from the mid-mediastinum down to, at least the gastrohepatic. And so just important to note, where it is and make sure that it's a reasonable field. But other than that, I think I would agree with the plan here. Carboplatin concurrent with radiation, I think is a great choice. And a squamous cell carcinoma in particular, we have very high path CR rates with the squames. There's a question of maybe induction chemo. I'm not sure that's necessarily something the group would think about, but if the periaortic lymph node were to be maybe very distal or something like that, maybe that would be a question to the group as to, is that a situation where we might consider induction?
Yeah, I think that if we were reviewing this case at our tumor board and there was concern for periaortic lymph nodes, which are quite distant from the mid-esophagus squamous cell, we might elect to start with induction chemotherapy. At the same time, chemo RT can be very palliative to this patient with a mid-esophageal cancer that they can't swallow, losing weight. And so even if it was overt metastatic, sometimes we still do the RT part to help definitively treat that area. Otherwise, it becomes problematic going forward. So the idea, though, of an induction chemo for a while, just to see how things go while the RT is getting planned, you're getting some treatment in. I think that is something that's reasonable. And we do that too sometimes.
And Dr. Patel, I'll just ask, I know it's not standard, but I'm sure some tumor board will discuss this as to whether there's any even experimental role for proton-based therapy for this patient.
Yeah, I think if we have a proton center at our center, so for candidates with localized disease, we're considering them for a randomized study, the NRG GI006 study, when we randomize proton and photon. This is typically for unresectable cases. So if we're planning surgery here, I think in that case, we may opt to provide the standard of care. But really the benefit of proton therapy, you can see on this axial slice right here, the heart is directly anterior to this lesion. So with a posterior proton beam, you're really going to limit the heart exposure, the lung exposure. And a large experience from MD Anderson has shown that the post-operative toxicity is much better with proton as compared to IMRT. So I think we're evolving, looking forward to the randomized evidence to support this. But I think we consider it in every case, particularly when we're going to have sparing of important critical structures like the heart and the lungs.
Very good. So Dr. Weiser, everything went well with this patient. The patient got their chemoradiation and now they're ready for esophagectomy. What do you think about the plan for surgery?
No, I think it's a good one. There are different approaches, but for this level of tumor mid-esophagus, a 3-field esophagectomy with lymphadenectomy makes sense.
So the crux of the question for this case is whether or not the patient should be considered for adjuvant nivolumab, particularly if there's residual disease after surgery. So Dr. Katsunachi, your thoughts on the yin and yang of giving nivolumab after this?
Great. Sure. So this is a very hot topic, and the one data set that we have at the moment to help instruct us here is the Checkmate 577 phase 3 study, which enrolled patients that had neoadjuvant chemoradiation and had successful R0 resection surgery, negative margins, and did not have a pathologic complete response. And so, and were otherwise eligible for treatment post-operatively. And so if the patient fit that category, then that would be a reasonable thing to at least consider. Some things that would be going through my mind, and just to reiterate some of the data, of course, the disease-free survival in that study, which then randomized patients to nivolumab for a year versus placebo for a year, essentially doubled the disease-free survival from around 11 months to 22 months. And that's the data set that we have so far at the first look. Some of the things to point out, though, are that looking at PD-L1 score of the tumor, the patients that had a PD-L1 score of combined positivity score of 5 or higher had a tripling of the disease-free survival. And the patients who had a PD-L1 score less than 5 had a non-statistically different disease-free survival. So that might be going through my mind, especially in this patient who's got Linus, what was it that they had some potential autoimmune issue. And so you'd always want to be concerned about causing more harm than good in that situation. So the data are very early. We don't have longer term follow-up. We don't have long-term survival, and we don't have long-term survival by PD-L1 score. So for now, though, the textbook answer is that all patients that fit the category of eligibility would be eligible, but I would be hesitant for a low-level PD-L1 score.
And then comments on squamous versus adenos in that trial?
Yeah, so both squamous and adeno were eligible for that study. As might be expected, the squamous cell tumors did better than the adenocarcinomas, because we do see that in almost every study that's been done that does mix the histologies, is that the squamous cells seem to be more sensitive to these checkpoint inhibitors. And so again, this is a patient with squamous cells, so I think that would be appropriate. And I wouldn't think twice if the PD-L1 score was high here.
Okay. And then I have to be honest, I read this question two different ways. One is whether there was residual disease, meaning a non-path CR, and I think you answered that question in your comments. But I also read it perhaps as an R1 or greater resection. So which obviously those patients were not eligible for the study. So if this patient had a non-path CR and an R1 resection, would you consider the nivolumab?
Yeah, it's a tricky one, because technically they're not eligible. And in fact, I've had a case like this where I think that's a very high risk of recurrence, and particularly if the PD-L1 score is high, I think that's just a matter of time when the patient's going to recur. So I would consider trying to get nivolumab in that situation. You could also make the argument that it's locally advanced, unresectable, or even metastatic now, and use the first line approvals of immunotherapies in that particular situation. So yeah, I think that, again, with the filter of PD-L1 score, which I think is becoming more and more important.
Okay, great. So I think to summarize this case, unless anybody has anything else to add, we would suggest that the patient absolutely is appropriate for preoperative chemoradiation, with carboplatin being one of the standard offerings, the radiation field being standard radiation, but there are some interesting approaches right now in the context of clinical trials of using proton-based therapy, that esophagectomy after treatment would be appropriate, and that this patient would fit under the category of checkmate 577 if the residual disease did not mean an R1 resection. But either way, that postoperative nivolumab would be very appropriate.